eventually be on the VETgirl website. Really excited, super awesome topic. We're going to be talking about the top 5 reasons you might need rapid fluid therapy, not just fluid therapy, because we're all ECC crazy people. Rapid fluid therapy. As many of you know, we like to say hello to everyone. We have Jose from Portugal, our awesome Portugal friend that's always on with us. What we love, and you know this if you've been on an event with us before, type in where you are logging in from around the world. I used to say from around the country, and then all of a sudden we have Portugal and Canada and Europe and Spain and all these crazy places. So let's see, we have St. Petersburg. Again, we have our Portugal. I'm Garrett Paxinger. I am logging in from kind of dreary Pennsylvania, just outside of Philadelphia. Justine, what about you?
I am logging in from St. Paul, Minnesota, and it is 90 degrees all week, and like the Minnesotan in me is melting. So
still wearing this sweatshirt. And we have our amazing speaker, Amy Newfield. Amy, where are you logging in from right now? It's almost like, you know, where in the world is Carmen Sandiego? Where in the world is Amy Newfield? There's an old, talking about the .nets and the hotmails and that. If you know Carmen Sandiego, that you're old enough to know this. Where are you logging in from today?
I am logging in from Massachusetts, and it's actually pretty nice, humid for Massachusetts, but it's about like 75 and sunny, so I'm good there. So yeah.
Awesome. And we have, let's see here, Robin from Maryland, Kat from California. We have Jenny from Long Beach. Oh, Long Beach. Maybe we should all go there. Sarah from Philly, Melinda from New Jersey, dreary New Jersey. Melinda, maybe you're by me. Washington State, see, all over on the West Coast. Alaska, love it. Lindsay in Alaska, 8 a.m. there. Good morning. California, Pennsylvania, more California. So really all over the place. I love it. I love it. So we'll give everyone just a minute or two to log in and get oriented and acquainted. We'll get into our normal logistics about race approval and all that good stuff so you get your CE certificate. But yeah, we love it. Keep typing in. We have India. Oh, that's so awesome. We have Arizona, India, Portugal, more California. So this is awesome. This is so cool. Nancy from Cali as well. A lot of Cali people. Must be good morning to you. It's about 9 a.m. your time. So really excited you're all online with us today. Let's get the ball rolling here. We want to get started. So again, I'm Garrett Paxinger. I'm the co-founder of VETgirl. I'm an ECC specialist along with Justine.
I'm Justine Lee. I'm an emergency critical care specialist and toxicologist. And thank you guys all for showing up to learn with the amazing Amy Newfield, one of our ECC peeps. You guys are in for a treat.
And we'll get to Amy in just a minute, but I want to go over just a couple of housekeeping things. And then I promise we'll make that small slide a little bigger so you see the full presentation. This way you can see all of us and our amazing enthusiasm. I first wanted to start by saying and thanking an amazing educational partners. So we have the Veterinary IV Systems. With their generous support, we're able to provide this RACE-approved continuing education lecture completely complimentary to the veterinary world. And I'm going to tell you how to get your CE certificate very shortly. So stay tuned. We're going to give you more information about VIVS, or Veterinary IV Systems. So thank you to them for being an amazing educational partner. And we're going to be talking about their awesome device in our rapid fluid therapy discussion. But this is really cool. And I am going to make this slide big just for 1 second so you can see it all. Here we go. Okay, so here's the deal. That is a QR code. If you use your camera, and I'm going to show you how to do that in a second with a QR code, the first 100 people that fill out this form with their QR code will get a free infuser and 12 of their cartridges for awesome and rapid fluid therapy.
Do it now.
Do it now. That's right. Do it right now while I'm talking. After the first 100, the rest of the people will get a discount code for 50% off of the price. And I'm super excited. They're also going to be at VETgirl U. They're one of our amazing exhibitors in just about two and a half weeks. We are all going to be in Chicago for our second conference, VETgirl U 2021. We still have a couple of seats left. I'm going to show you how to use the QR code in 1 second, and we'll bring this slide up in just a minute again. But please make sure you fill out that form so you get a free infuser as well as 12 cartridges. And if you're not one of the first 100, you'll get a 50% discount. Next thing I want to show you is, let's get into some housekeeping. This is really important to talk about some housekeeping. So what is VETgirl and what do we do? We are the #1 CE provider for busy veterinary professionals, and we offer CE in a multimedia approach. Like this is a YouTube live event. We do webinars, rounds, podcasts, blogs, and we have content all across the board: small animal, large animal, technician, practice management, real life rounds, you name it. So we love doing what we do. Everything that we give is RACE approved. Our practice management and leadership tracks are also CVPM approved. So if you're not familiar with the VETgirl platform, please check it out. We have thousands and thousands of associates that love to learn with us. We've built an amazing community. We love our community. We hope you join if you're not part of our community yet. We also have an awesome discussion board. So whether you want to vent over a venti, whether you want to ask a case question to a specialist or get some input about something you're seeing or a job posting, all of our members have access to our forum and our discussion board. And as you know, this is on YouTube, but we're all over social media: YouTube, Facebook, Twitter, LinkedIn, Instagram, Pinterest. Even maybe Justine will dance on TikTok later for us. You never know, but just make sure you're interacting with us on social media. Definitely know, says Justine. All right. So again, QR code time. This is how you get your CE certificate. This is the same thing as the other QR code for the Veterinary IV Systems. Here's the deal. Okay. I have my iPhone right here. You see me in there now. If I just point my phone right up to it, like I'm taking a picture of that QR code, I get a little Safari link. This is my iPhone at the top. I click on that, up comes the form for me to fill out. It's the same exact thing with their QR code. If you don't have the smartphone, Justine just posted in our YouTube chat that URL, right? You can just type that in, tinyurl.com/VG. MIVS21. It takes you to the same exact form. If you fill this out, we will send you a CE certificate usually within 48 to 72 hours. This session is live from approximately 12 to 12:30 Eastern time. We'll probably go a little bit longer. I will leave this form open until 1:30 p.m. Eastern. If you want live interactive RACE approved CE, please make sure to get this form filled out by 1:30 p.m. Eastern. No exceptions. It will close at that time. Again, you can use the QR code camera feature or type in the URL either on the screen or what Justine posted in chat. I promise to show both this QR code as well as the Veterinary IV System QR code at the end of the session, just in case you missed it or late or want it again. And finally, last housekeeping thing. Again, I promise we're going to make our pictures are going to go away. You'll see the slides nice and big. Like any YouTube video, in the bottom corner, you see my little arrow there, that little box. If you click on that, it becomes the full size of your monitor, not the smaller YouTube type screen, so you can see it even bigger. With that said, Justine and I, we're cool people, but I know you're not here to listen to us today. We want to hear from the amazing Amy Newfield. So Amy, if you can, we're going to mute ourselves. If you can take it away, I'm going to leave the floor to you. Give us a little introduction of what you love to do. I know you're in Massachusetts now, cool things, and then take it away. The floor is yours. We'll be behind the scenes. We'll get to questions again at the end. And again, thank you so much for being here with us.
Of course. Thank you guys so much for having me. I'm super excited about this. So like Garrett said, my name is Amy Newfield. I'm a VTS in emergency critical care. So I love all things geeky emergency. That's one of my crew members. His name is Blitz. He is what I call my little demon, but also comedian dog. He thinks he's super funny, but he gets in naughty trouble all the time. So what I love is trauma, and I love trying to fix it. When I work floor shifts, which I still do and can't imagine ever giving that up, I absolutely love when trauma patients come in and I have the ability to watch them go from dying in front of me to hopefully feeling better and getting to go home and keeping that pet owner bond safe and sound. Garrett, next slide. So we're going to talk about rapid fluid administration. So what is rapid fluid administration? This is where time is of the essence. These animals present often in a decompensatory or terminal stage of shock, usually from some type of shock or trauma or some massive disease process that is usually really acute and severe. And so we're going to be talking about fast fluid administration that helps to return these hemodynamics back to normal so that we can go ahead and really focus on kind of tailoring those fluids to what that patient needs. Garrett, next slide. So there are several types of fluids, and depending on the trauma, it depends on which one you want to choose. And we're going to kind of dive into the 5 most common reasons that we're going to need fluid therapy and sort of what's the best choice of fluids for these. So we have our crystalloids, our colloids, and our blood products. And yes, you can rapidly administer all of them. So we're going to dive into those. So here's the top 5 reasons, lots of acronyms, right? So hemorrhagic gastroenteritis, your bloody diarrhea, your HGE, your gastrodilation volvulus, your GDV, vehicular trauma, your diabetic ketoacidosis, and your hemoabdomens. Those are typically your top 5 reasons. And your HGE patients, so when these guys present, which are always on a Friday at 5 p.m., right when you're trying to close up your hospital door, comes in the dog and then squirts bloody diarrhea all over your waiting area. These guys usually experience massive fluid loss. When you look at that image there of the chocolate lab who has now sat in his diarrhea and then wallowed in it and wagged his tail in it. It's always, I don't know why they get to do that, but they do that. That's because he's rupturing blood vessels in his lower gastrointestinal tract. And so now we're seeing just blood profusely coming out of his rectum. So we're talking about a very quick onset of dehydration. Sometimes, but not always, HGE will present with the initial vomiting. The owners might say he missed a meal or he had 1 episode of vomiting, and then very quickly, they might have 1 or 2 bouts of diarrhea, but it turns bloody very quickly. These guys often present in shock. Sometimes it's an early stage of shock where their heart rate is just elevated, 170, 180 beats a minute, but their pulses are still good and they're still relatively pink. But a lot of these guys, because unfortunately they've lost so much fluids rectally and sometimes also through oral vomit, they are usually in a decompensatory stage of shock. Next slide, Garrett. So we're going to be talking about crystalloids, but there are 3 types of crystalloids and only one that you really want to use here. So we've got our isotonic, so that's right in the middle. That's the most common things that are in your hospital. So you're talking about lactated ringers, 0.9% sodium chloride, or norm R, P light, things like that. And that's really going to be our focus. We are going to talk about, when we can use hypertonic saline, but it is 7 to 7.5% sodium chloride. So just looking at it on a surface level, and we just talked about dehydration, we're not going to want to use hypertonic saline because unfortunately we've got a massively dehydrated dog, and 7 to 7.5% sodium chloride, it's salt. That's what it is. So if you've ever had eaten a lot of salty foods, yeah, you probably don't want to add salt to being dehydrated. And then hypotonic, that's kind of the weakling of the bunch. That's your D5W, your half-strength saline. The problem with this fluid is that when you put it in the vessel, it just redistributes too quickly, and it's not going to really make a huge change on the hemodynamics. Go ahead, Garrett. So isotonic crystalloids, that's going to be your most common fluid used for your HGE patients. It's very similar to your body's extracellular fluid because it contains similar electrolyte concentrations. Go ahead, Garrett. So they distribute very quickly. When you put it into the vein within about 30 minutes, 75 to 98% of the fluids shift into the extravascular space. That's not a bad thing, but that's why you need large volumes in order to make a difference. And so when we're dealing, say, with a 90-pound or a 35-kilogram big Labrador, we're going to need maybe a liter or more in order to rehydrate this HGE patient. And really, we want to just continuously give these fluids because we have to not only treat the level of dehydration, but keep up with the fact that this dog is still having diarrhea. And so the shock doses, I think we're all pretty familiar with these, but for our dogs, it's 20 to 40 mils per kg over 15 minutes, and cats anywhere from 10 to 20 mils per kg over 15 minutes. And after each bolus, we really do want to take the time to reassess our patient. How is their level of shock? If they're in a decompensatory state, they usually have pale or muddy mucous membranes, weak-ish pulses. They might have a pulse, but it might not feel very good. They're still usually in a tachycardic state. And so after that initial bolus, we want to see the heart rate come back down to normal. We want to see the gum color pink back up. We want to absolutely go ahead and start to feel the pulses get improved. Now, the total volume that we can give is 70 to 90 mils per kilogram, and in cats, it's 35 to 50 mils per kilogram. Now, for those of you who have been in veterinary medicine for a while, especially if you've been working since the 90s, we used to give trauma patients or shocky patients the full volume dose almost every single time, and it turns out we might have overdone it. So remember, you can give more, but you can't take away, which is why we did these smaller boluses. We're just going to start with 20 or 30 mils per kilogram, reassess the patient in a dog, see if they're doing better, and then continue to give another bolus if we're still seeing, yucky looking gum colors or bad blood pressures. Go ahead, Garrett. So gastric dilatation volvulus, this is the prevention of adequate blood return to the heart from the abdomen. So we all are very familiar with the stomach getting enlarged, it flipping on itself, and now we've got no blood supply to that stomach. But as that stomach expands, it actually compresses the vena cava. And as we know, the vena cava is our main vein that supplies blood to the heart. So this is obviously a huge body-wide issue and is an emergency that happens very quickly. So we see this loss of blood flow also to the lining of the stomach, which results in an ischemic episode, unfortunately. And so our fluid therapy is focused on reversing shock. These guys were normally hydrated prior to coming in, but now they're experiencing an obstructive shock. Go ahead, Garrett. So we want to choose either isotonic crystalloids or hypertonic saline. So we've already talked about isotonic crystalloids. So let's talk about hypertonic saline. So this is that salt solution I was talking about. It's 7 to 7.5% sodium chloride. It has a really high osmotic pressure. So normal osmolarity when we're dealing with an isotonic crystalloid is somewhere like 250 to about 310. I'm going to show you a slide that's going to blow your mind when it comes to how high the osmolarity pressure is in this. It is really useful for when large volumes can't be given fast enough. So I think really much about that terminal stage of shock. They are laying on their side. They may be tachycardic, but they're moving into bradycardia. They have no pulses that are palpable. They have pale, if not blanched white gum color. They're fairly non-responsive, and you know they're going to die soon. That's where we want to utilize hypertonic saline, because one dose equals 4 times the volume of isotonic crystalloids. Okay, next slide. So how does it really work? What it does is, you know, arguably there's other forces involved when we're talking about fluid shifting and fluid distribution, but Starling's forces still seems to be the Bible of why fluid stays where it is or moves why it does. And so this causes a rapid increase in intravascular volume until Starling's forces bring the equilibrium back to across the capillary membranes. So the best way I describe it, and do not do this, this is one of those disclaimers, don't do this, but we all know what happens. If you had a snail and you think about that snail and how moist and, you know, slimy it is, and you went and poured table salt on it, what happens to that snail? It gets dehydrated. Now I want you to also think about taking some table salt, putting it on the table right next to, but not into, a drop of water. Over time, that drop of water will get sucked into the salt. That's just what absolutely happens. And so now I want you to think about pouring table salt into a vein, because that's essentially what we're doing. And in that time frame, that salt that goes in the vein, what's going to happen to the fluids outside of the vein? Yeah, they're going to get sucked into the salts. That's exactly what happens. And so yes, in some level, we are going to dehydrate the extravascular space in an effort to increase the intravascular space so that we can get our blood pressure up, we can get better perfusion to the heart, and we can very quickly reverse shock. So what we don't want to do is obviously use in our dehydrated patients. Patients already have a high sodium, so our hypernatremic patients, hyperchloremic patients, or anything that's hyperosmolar patients. All right, next slide. Okay, here's that slide. So remember, osmolarity on our isotonic crystalloids are anywhere from about 250 to 310. This is 2,396, and look at the sodium content. To put that in perspective, at our 0.9% sodium chloride has 145 milliequivalents per liter of sodium. This has 1,197. That's not a typo. So again, you're basically pouring salt in, but very quickly you can help reverse the stage of shock that your GDV patient is in. Go ahead, Garrett, next slide. So this is also known as limited volume resuscitation. So we're talking about roughly 4 mils per kilogram over 5 minutes. You're only going to do it one time, okay? This is a very potent fluid, and you really only want to do it 1 to 2 times. So you're going to reassess the patient and maybe do it a second time if they're really struggling. But here's the reality. Remember, we dehydrated the extravascular space. We need to follow up with isotonic crystalloids, because what does crystalloids do? The isotonic version, it goes into the extravascular space, and we're going to rehydrate those tissues that we stole fluids from. And so again, consider this type of fluid if they're in a terminal or decompensatory stage of shock. Next slide. Vehicular trauma, your hip bys, right? So up here in New England, we've got our hip by snow plows. Down in Florida, you might have your hip by golf carts, right? So any type of vehicular trauma is what we're talking about. So in these cases, they can come in either two types of shock, and maybe it can be a combination of both of these, but hypovolemic shock, where we're actually seeing blood loss, and maybe it's because they have a hemoabdomen, or they actually have blood in their thoracic cavity, or a massive compound fracture and they're bleeding, hemorrhaging from their femur, for example. Or distributive shock, where, and I find in my own personal experience, most of them are in a distributive shock. They aren't necessarily bleeding out, but they still have the pale gum color, the poor pulses, if any pulses. They look clinically like they're in shock. They're cold to the touch. They actually have a low core body temperature, but we don't see any evidence of internal bleeding. And that's because they have done something called fluid shifting. In that time of shock, they have shifted their fluids from the non-essential areas, which is like their legs and their GI tract and even their liver and their kidneys, and they've pushed it to blood pool in the heart, the brain, and the lungs, because the body realizes it needs most of its blood volume in those three most important areas in order to stay alive. And so we need to quickly determine what type of shock so that we can help direct the fluid therapy. Go ahead. So we can think about things like isotonic, hypertonic, or blood products, depending on what exactly is going on with this vehicular trauma. Go ahead, Garrett. So if it's a head trauma patient, this is why I love every hospital having hypertonic saline. So it is the one type of fluid that I find that a lot of veterinary hospitals who practice general medicine don't necessarily have. But the thing about hypertonic saline is it lasts forever. It has an expiration date that is so long because it's super salty, so nothing grows in it. And it's really inexpensive. So it is the ideal choice of fluid because it only requires a small volume of IV fluid. And think about pouring salt on a swollen brain, going back to that snail analogies, right? So when you pour salt on a swollen brain, it's going to shrink. And so it's going to help reduce that cerebral edema, but it's still going to increase your arterial blood pressure. This is the fluid choice for in both human and veterinary medicine when we're dealing with our head trauma patients. So that's why I love every hospital have it, because at some point you will have a head trauma patient that comes in, and this is the fluid choice for that. Go ahead, Garrett. So we also want to think about like with like. Now in human medicine, this is just sort of the Bible. They replace like with like all the time. So if you're bleeding, they give you blood. If you're losing coagulation factors, they give you plasma. If you are losing albumin, they give you albumin. Now, I understand in veterinary medicine, we don't have that luxury, but we do want to consider blood transfusion in patients that are clinical for anemia, regardless of packed cell volume. There have been plenty of trauma patients where we have started a blood transfusion and their PCV is 30% or 32%. And I know a lot of you are saying, but textbooks say under 22 or 24%, depending on what you're looking at. It doesn't matter sometimes how many bags of crystalloids you pour into your patients, or even if you start going down the road of colloids that we're going to talk about, synthetic colloids in a little bit. That patient is clinical because it doesn't have blood and it needs its blood back. So in order to reverse the shock, sometimes we do need to go with like replacing like, and we're going to talk about auto transfusions in a few slides to help you guys out. So DKA, this is defined as a chronic hyperglycemia of greater than 600 mg per deciliter, also greater than 33.3 millimoles per liter. And here's the thing about DKA patients and chronic hyperglycemia. This didn't just occur overnight. We're talking about days, if not weeks, if not maybe a month of just these really high blood sugars. It all leads to just severe dehydration. That's all it is. It's just massive dehydration. And ultimately, this massive dehydration is they increase their thirst, they increase their urine production, and they have both intra and extracellular dehydration. Go ahead, Garrett. So these guys might present in shock. So in those cases, you know, we can volume resuscitate, obviously, with isotonic crystalloids, and that's usually, it should not say starry, it should say start. Sorry about the typo there. Starry with crystalloids. It sounds like a starry night. But start with crystalloids. You want to start with crystalloids, and then consider maybe synthetic colloids. Now, I know some of you are like, oh, she just talked about synthetic colloids. No. All right, so let's dive into this colloid controversy for like the 30 seconds that I have to give to it. there is a hard, concrete evidence out there. In fact, there was a Cochrane study done, I would say about 7 or 8 years ago, with about 10,000 human patients. And this Cochrane study pretty much conclusively determined that anytime hydroxyethyl starches, of which there are 3, so you have your hetastarch, which is your biggest molecule, and then you have your vetstarch, which is your smallest molecule. In the middle of that is pentastarch, but nobody in veterinary medicine uses the pentastarch. So we've got our hetastarch, which is like Hespan, and then you've got your vetstarch, which is like your vetstarch for by Abbott, or Voluvin if you're international. And so in that moment of doing those studies for the Cochrane studies, they conclusively said no matter which hydroxyethyl starch you choose, there is an increase for renal failure, which will put you on dialysis, an increase in morbidity and mortality, an increase for clinical bleeding and coagulation factors. These products are no longer recommended. In veterinary medicine, though, we have to realize that dogs and cats are not people, right? And so a lot of times we steal things from dogs and from human medicine and try to use them on dogs and cats, and they fail, or sometimes it works. There was a consensus study done about 5 years ago, published in JVEX, and they basically said that while there is some clinical evidence to support that our patients might have a slight increase in renal failure, and yes, by the way, we've had studies out for over 20 years in veterinary medicine that has supported that on a microscopic level. There are coagulopathies that occur, but there's no actual evidence of clinical bleeding. In fact, there was a surgery study that was published, I want to say 2015, on TPLOs in healthy dogs, and they found that their patients didn't bleed any more or less if they were on lactated ringers versus on a synthetic colloid. So we're not seeing the evidence of clinical bleeding, or at least study-wise, that they're seeing in human medicine. But the consensus study out of JVEX basically stated that more study needs to be had. And I think when we're using these products, if you're fighting with blood pressure and you've got this DKA dying on you and you've boluses of crystalloids and this cat or dog is not responding to you, perhaps reaching for a hydroxyethyl starch, you should do so, but be very careful. And I know, most of my doctors that I work with right now tend not to reach for it, but every so often I have a doctor who still uses the product. So that's kind of the low down skinny on the colloid controversy. But in dogs, we're looking at anywhere from 10 to 20 mils per kg over 15 minutes. And in cats, about 10 to 15 mils per kg over 15 minutes. Okay, next slide. So we want to correct the dehydration after you deal with the shock. Go ahead, Garrett, next slide. And so we do need to focus on replacing the volume in these DKA patients. So focus on the shock. And then really, I think we're all familiar with how you replace fluids, right? Estimate the percent of dehydration, multiply by the body weight in kilograms. That equals the total volume in liters. And so we typically correct about 75% of that over the first 24 hours and the other 25% on the second day. And most of the time, we're going to continue to do replacement fluids with isotonic crystalloids. And then the hemoabdomen, right? So hemoabdomens can occur for a variety of reasons. Trauma, splenic ruptures, your GDV torsions, right? Your tumors, and your infamous, what you see here, your golden retrievers with their hemangiosarcomas. Next slide. So this is where I want to talk just very briefly about auto transfusions, okay? So auto transfusions are the thing you should consider in these patients that have clean blood. So if it was a gunshot wound or stick in the abdomen, that's probably not going to be something you want to put right back in the vein. But otherwise, we talked about replacing like with like. Go ahead, Garrett. So they are not dirty and they do save lives. Auto transfusions are really easy to do. No anticoagulants are needed because fibrinolysis has already occurred. So you just rapidly infuse the blood that you take out of the abdomen or the chest cavity and slam it back into the vein via a filter. Bags themselves, if you can have them hanging so that you're not forcefully pushing it through a syringe, is going to be better just to help salvage as many blood cells as possible. But definitely consider that. So let's just dive into the last minute or two that we have of how to administer fluids rapidly. So first of all, you need yourself a big short catheter. You don't want the 2-inch catheter. You don't want a 2-inch 24-gauge catheter. That said, I know that it might not be possible to get the largest gauge catheter in, but larger is better because what they have found is that by increasing the gauge of the catheter by only 1 gauge, you can reduce the bolus time of a bag of crystalloids from say 6 minutes to 2.7 minutes. And when every minute counts, it's important that you try to get the biggest catheter in. You're gonna think about potentially a pressure bag. So this is a hand pump. I've got a video of that. That does allow for rapid administration. This new MIVS IV system, which I'm gonna show you guys, the company let me try it out, and it is really cool. I'm not gonna lie. I think everybody in the rooms, their faces were just in wow of this thing. And then fluid pumps. It is time consuming to set this up, but I want you guys to consider fluid pump because it offers the most accuracy, especially when we're doing say 20 or 50 mil boluses on our cat patients. We can't risk bolusing 200, 300 mils by accident. So definitely think about a fluid pump. Next slide. All right, so you can press play on this, Garrett. I think we're all familiar with this old-fashioned bag, and I say old-fashioned even though this is what we all have in our hospital, but wait until you see the new bag, which is just like a high-tech version, but way cooler. We're pumping, and 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 we're still pumping, and we're pumping, and we're getting hand cramp, and we're pumping, and we kind of all feel how big the bag is getting, and we're like, is it going to explode? I have no idea. And I've actually heard of people exploding these bags before, and pumping and pumping. And on the little thing, there is essentially a little pin that comes up and it'll show you that you're in the green. And then when you're ready to go, you go ahead and just start the fluids. All right, next slide. All right, so this is definitely a cool new toy. I was so excited to play with this, and there was a lot of wow factors. So it basically has this pressure bag like you see here, and then you have these CO2 cartridges. Yup, it is just as cool as it sounds. Go ahead, Garrett, next slide. So here it is. So you basically just slide the bag in just like you would with your regular pressure bag, and if you want to hit play, we'll talk them through it. So you're just gonna put the fluids in there. And then what's going to happen is you took the CO2 cartridge, attach it to the bottom, pull the red thing off, continue to go ahead and tighten the CO2 cartridge. It will get cold. If you've ever had any experience with CO2 cartridges, they do get cold. So it will get cold. And then it goes ahead and just blows up on its own. It's pretty awesome. You don't have to do a thing. That's it. It just blows up. And it applies the exact same amount of pressure that you would need to get those fluids rapidly into that patient. There's a little red button at the top there, and you'll see it's going to slowly start to go up. I'll zoom in, but that's going to tell you exactly how much pressure is being administered. The cool thing about this is you definitely want to hang it vertical, but you can also hold it vertical. If you lay it down flat, it will still go at the same rate, but the concern is if you're laying it flat, the air bubble could certainly get in there, and then we don't want to do that. And then I did a side-by-side comparison, so I blew them both up, and then I went, go. And here's the problem with the regular pressure bag. We have all been there. We need to add more pressure to it. So I'm pushing, and I'm pumping, and I'm pumping. Meanwhile, the other one's just flying into the veterinary patient. Meanwhile, this one, I'm like, oh, okay, we're going to get there. We're going to get there. Still not quite there. It's just was really amazing how fast the other one goes. The other one's still going. I could walk around with it. And the cool thing is if you're a veterinary technician or a nurse, you don't need to necessarily hang it up. You can just hold it above your patient and it will do its job. And so fluids are flying in pretty quick, which is awesome. Next slide. And then just to go ahead and deflate it, you just pull up on the little red thing. It does make a little bit of a hissing sound, but in my opinion, it's way less of a hiss than the other one. And if you're doing cats and working with cats, you guys all know how this is. Even if you're given sub-Q fluids, that cat hears the other hiss, it's like they fly off the table, right? Not cool at all. So this one does hiss, but it's actually a way less of a hiss. All right, next slide. So in conclusion, rapid administration of fluids is needed for a variety of diseases and illnesses in veterinary medicine. Having a good understanding of fluids and stages of shock will hopefully help you stabilize your patient further. So, and I'm happy to take any questions. I know that was rapid fire, much like rapid fluid administration.
No, Amy, that was awesome information. So I do want to, as promised, I do want to get to a couple of housekeeping things as we talked about in the beginning of the session. So number one, all right, I'm going to show this to you again, and then I'll make it big for you one last time. So you see the QR code from the Veterinary IV Systems. I take my normal phone, look like I'm taking a picture of that QR code. Okay, a little Safari screen comes up here. If I click on it, up comes the form, okay? Again, the first 100 people that fill out that form will get a free infuser as well as 12 cartridges. Awesome information, awesome product. As after the first 100, you'll get a 50% coupon code, discount code to get the device as well. So thank you so much to Veterinary IV Systems, not only for that awesome thing. I mean, you guys better get to this because I'm going to start typing in. I want a device myself. I didn't get one. Amy got one. I didn't get one. So I'm going to, you may only have 99 spots left if I get to you first, but please go ahead and do that. And then as I promised, let me just do this really quick. I do want to make this big in case your screens are small. So I'm going to let that go really big for 1 minute. And then what I'll do as well, reminder, so that QR code is up. Hopefully you all got that. Number 2, again, this is live. This is interactive. We are live with you right now. It is about 12:35 Eastern. This is the VETgirl QR code. So a very similar thing, as I said before, take a picture, go to take a picture of it or type in that small URL. This is to get your race-approved live and interactive CE certificate. I will keep this form open until 1:30 p.m. Eastern, so you still have about 55 minutes as of now to do that. At 1:30 p.m. Eastern, I will close it within about 48 hours. You will get your CE certificate. If, let's say, Friday rolls around and you have still not received your CE certificate and you think you're online live with us, just shoot us an email and we'll make sure to check that out. So let me unsolo this so you can see our smiling faces. Once again, here we are back. So with that said, I'd love to get to some questions. I'll leave this coupon code up. I'll put the Veterinary IV System QR code up again in just a moment. But if you have questions, please go ahead and type that in. We're happy to get to some questions. Amy, I'll highlight a couple of points that you made because obviously this is right up my fun alley. I feel like fluid therapy is what we all do on a daily basis as ECC people, but at the same time, I mean, everyone does fluid therapy. Some more rapidly or stressed than others, like myself, in certain coffee days, right? Cups of coffee, but I love the fact that you talked about the difference between the types of fluids. I agree with you. I'm much more on the isotonic crystalloid and hypertonic crystalloid bandwagon. I'm going to raise my hand and say I still use synthetic colloids. And part of the reason is, listen, the reality is this. I mean, you talk about all the amazing products that the human field have immediate access to, albumin products, other blood products, plasma products, things that are more ubiquitous. In the veterinary field, based on cost or availability, we just don't.
Yep.
That's the problem. We just don't. And so the issue is we just don't have the other products available. So I am still in my opinion, in the right situations, I'm still using synthetic colloids. I love the fact that you talked about, the number that I always give is, and you're right in that range, 75% of the isotonic crystalloid that you give will leave the intravascular space and go to that interstitial space within about 30 minutes. Same thing with, it's a crystalloid, your hypertonic's just the same. And so we have to remember, we have to chase with something or else it will leave your intravascular space. You may not have the long-term effect, which is why we always talk about, I don't say, don't set it and forget it, right? There's always reassessment. You give the fluid bolus, you reassess the patient, and then you continually reassess the patient to see how they're doing following these events. So that's another awesome point that you made. And I've seen the awesome product from the Veterinary IV System group before. It is so cool because, the reality is we usually don't have 74 hands on deck all ready for their little jobs. And you more than me, as a veterinary nurse, a veterinary technician, you're probably doing 87 things at once. And so if you can give up one thing, meaning I don't have to pump while I'm trying to put another catheter in or get the oxygen line or hook up the EKG machine or get the blood pressure machine, you know how it is. I mean, if any of my nurses are online with me, they know I'm barking orders left and right, pun intended. And like, I only have 2 hands. Well, guess what? Now you have a third hand. You don't have to be constantly squeezing that to make sure we get that fluid bolus. So really awesome information. Jessica, I'm gonna approach this question. I love it. So Jessica asks, I've heard about combining hypertonic saline and hetastarch to increase that time the hypertonic stays in the vascular space. Any thoughts? So Jessica, I love this. So the way I was taught this when I was a resident at Penn, we used to call it turbo starch. That's what we jokingly called it. And just like we're talking about, the reason is because hypertonic crystalloid is still a crystalloid. So just like we said, 75% will leave that intravascular space. So in my opinion, the way I describe it is the hypertonic saline brings fluid from the interstitial to the intravascular space, and then the colloid keeps it there.
Yep.
And so what we used to do is, Amy made a great point. The other thing I was going to make is she talked about hypertonic, and the percent she gave was 7%. The bottles that I had when I was a resident were the 23.4%, and we can't give that. Look at the numbers Amy had for the 7%. That's way too hyperosmotic. And so the cool thing is we wanted to get that 23% down to about the 7%. So 23.4, a third of that is about 7.2%. So we would get a 60 ml syringe. We would take 13 mils, if I remember correctly, of the hypertonic 23.4%. So 17 mils of that, and then 43 mils of the colloid, and you would automatically reduce that 23% down to your 7%, and we would give for a dog about 5 mils per kg of that. So the fun thing is you didn't have to do any math, right? It wasn't like, well, if the patient's 3 kilograms, and then I need 5 mils per kg, that's 15. And if I carry the 7, divide by 4, and do the square root of Amy Newfield, what will that be? No, you get a 60 mil syringe. And if we said 5 mils per kg for a 3 kilogram dog, that's 15 mils. So you give 15 mils of that combined concoction in that syringe, and you have left over to give a second bolus if needed. So Jessica, I love turbo starch. Yeah. Thank you for bringing it up. It's one of my favorite things to chat about. Amy, is that your experience, or what do you do?
It's a great call out. So there were some studies that were published that suggested chasing it with head of starch actually allows the effects to last anywhere from 20 minutes to another half an hour. The only reason I didn't mention it is because the colloid controversy. Yes. And so, and I did see Justine put in the notes, she's not afraid of synthetic colloids either. So you both are okay with the synthetic colloids. Okay. Currently, most of my criticalists that I have been working with are terrified of them. So I think it really varies. I just think we got to be careful whenever we're doing any type of fluids. I also saw 2 call outs on auto transfusions. So somebody asked, I've not heard of this. What is this? So auto transfusion is using the animal's own blood. So if you think of a belly filling up with blood, or even a chest cavity filling up with blood, as long as it's clean, as long as it's enclosed and it's not like, again, stick through the abdomen or pus coming out of the chest cavity, you can go ahead and take usually a catheter. Some people use a needle, and just filter that blood into ideally a bag, because that's the easiest way, so you're not sucking out. But in terms of emergency, most of us are syringing the blood out of their abdomen. That's more realistic. And then you're going to, in a perfect world, hang it from a bag and just allow it to drip quickly back into the animal's vein. There's going to be some lysis of red blood cells, but you don't need to do any sort of cross-matching or blood transfusion. It's the animal's own blood. You literally just give it back to them. But it's still better than not giving them any blood. And so consider an auto transfusion. Here's the only thing to that. While I do absolutely love that pressure bag, do not put your red blood cells in a pressure bag, or you're going to squish them and kill them, because red blood cells are delicate little babies. So we want to try to just put it in a little bag, drip it in, or maybe as slow as possible to try to get it in there syringe wise. But also I will mention sub-Q fluids, because you mentioned, Garrett, just freeing up nurses and technicians. Man, when a doctor says, can you do 500 or 900 or a whole liter of sub-Q fluids on a big dog, you're like, that's going to take me forever. So now I want you to envision, rather than get a hand pump on that thing, or rolling the bag, we've all done that, or squeezing it in as hard as you can. You have this automatic system. And I will say this, I left the CO2 cartridge in there. I used it multiple times, and it still kept the pressure, which was actually pretty impressive, because I thought it was going to be a one and done thing. But I did it, and it was over the course of a couple hours. I would go back and just try it out, and it still maintained its pressure, which was actually pretty awesome. So yeah, plus there's nothing more cool than just plugging in the CO2 cartridge and the thing goes, and you're like, what? So yeah, and then you don't have a hand cramp at the end of it. So, but awesome. Don't use it for blood.
I will say, Jessica did ask a follow-up question about is the ratio of hypertonic to head of starch important? And from an academic ivory tower perspective, it is, because we're talking about the ratios again to have that osmotic pull and then the oncotic hold of that. The reality is this: I mean, even if you diluted the 7% down to 3.5%, you're still getting more than isotonic. So the ratios are only as important as the ivory tower academic discussion will be. You're still going to get some benefit. The question is, how much bang for your buck will you medically get? And if you dilute it more, the answer is less bang for your buck. do you ever do these fluids IO or IP in teeny patients, one without a discernible vein? So Jessica, I would answer, and then I'll pass it over to Amy. I don't think intraperitoneal fluids are, while they're not wrong in the sense of giving fluids, in the context of this lecture being rapid fluid administration, the answer is no, IP would not be what I would use. Now, IO, absolutely. I'm a huge proponent of intraosseous catheter placement. And yes, you can absolutely bolus. Now, because you're giving the fluids or blood or dextrose or whatever else to the trabecular meshwork of the bone, you will have more resistance than going intravascular. So you will be limited by the speed in which the bone will allow you to deliver the fluids. But you absolutely, my teeny neonates and small pediatrics, if I was to cookie cutter an answer, which I don't like doing most of the time, we're talking easily less than 3 months, unless you have some sort of advanced IO, easy IO, some type of device. But if you have a 2, 4, 6, 8-week-old puppy or kitten, you could probably take a 22 or 20 gauge needle and just drive it down. I like the femur to give it in. Absolutely, you can bolus pretty much anything you can give IV, you can give IO just the same. So I often give dextrose for these little things, because usually when I have these little things that need an IO, they're hypoglycemic, hypotensive, and hypothermic, the 3 hypos called Triple H. So usually I need both fluids and dextrose, and absolutely that can go IO. What about you, Amy?
Yeah, 100%. Again, not really for IP. I can't remember the last time I did IP. If it was something similar to that needed fluids that wasn't rapid, we'd go sub-Q. But IO, 100%. You can bolus anything you want IO. It works and is absorbed just as quickly into central circulation as IV is. So absolutely. And by the way, I love Rachel's comment there. 1 liter of sub-Q fluids to a dog is the worst thing you could say to a technician. I hear you. That is like, I don't have 25 minutes to be hanging around dealing with this while I'm pumping up and squeezing a bag, and y'all get hand cramps, and then you're like, this is my workout for the day. So yeah, totally. I love it.
and I would say a good 80% of the time that dog's also trying to bite you if it's a liter. If it's like 10 mils, it goes pretty quickly, no problem. It's the sweetest dog ever. The 1.5 liters you have to give to the big dog, that's the biter. So yeah,
it really is.
None of the nurses like that.
Nope, we don't.
I want to be respectful of everyone's time. We are a little bit past our normal 12:30 Eastern time hour. Just very quick reminders. Again, I have our Veterinary IV System QR code up there. Please make sure, again, the first 100 people that fill that out will get a free infuser as well as cartridges. After that, after the first 100, we'll get that 50% discount code. And again, last reminder, this is to get your CE certificate. Again, QR code or URL website link there. I'm going to leave this open for about another 45 minutes. So as long as you fill out that form by 1:30 Eastern, we will absolutely get your CE certificate usually within about 48 hours. I wanted to thank you all for joining us today. Really, really happy that you're with us. Super excited for you to be here. It's very exciting. We love seeing all of you from around the country and around the world. We thank you for doing that. I thank Veterinary IV Systems for being a great educational partner. As we said at the beginning of the session, it's with their generous support, we're able to provide this complimentary free to the veterinary world. So this will be on YouTube. This will go on our VETgirl website afterwards. We hope you enjoy this. We do have a VETgirl webinar this evening, so please make sure to check that out. I would also say we hope to see many of you at VETgirl U in Chicago in just about 2.5 weeks. Our next live conference will be there. I hope everyone has a great rest of your week and great rest of your day. Amy, again, thank you so much for an awesome presentation. All right, bye-bye, everyone.